If you have a meniscus tear or a suspected meniscus issue, the biggest question that you'll have is, should you have surgery where either you remove that meniscus or you repair it, or should you go through physical rehab and conservative management? And hopefully in this video, we'll just tidy it up and clean it up in your mind in a super quick and easy fashion. Now, if you do need help with rehab, I have a little meniscus program down below. But before we look really at management, let's quickly recap what the meniscus is, how we damage it, and how it presents. So the meniscus really is just a little spacer that sits between the two bones of the leg and the knee, so the femur and the tibia, so the thigh bone and the shin bone, and it sits between them, and its whole role is to dissipate energy. It also plays some role in proprioception of the knee, telling your body where the knee is, as well as making sure the joint sits really nicely together, and also some lubrication. But its main function really is to dissipate energy. And it's what we call a fibrocartilage, and we find this elsewhere in the body. We find it between the bones of the spine, the spinal discs, between the collarbone and the shoulder blade, between the wrist and the forearm. Anywhere where two bones butt up against each other, you will find these fibrocartilage discs that really help dissipate energy. Along with that, they also tend to be injured in the same mechanism. Usually we put some force on them, so we squish them and we twist. So in the back, it's putting our shoes on. In the wrist, it is things such as bending it and then twisting. So they all have a similar mechanism of injury. Now within the knee, the meniscus, we do have two. We have one on the inside called the medial meniscus and one on the outside called the lateral meniscus. Now the one on the inside is the one that's most commonly injured. This is because firstly, the knee uses the inside as its pivot point, so it experiences more force. It's also attached to the ligament on the inside of the knee, the medial collateral ligament, meaning it's rigid and stuck in place. So if we do move, it doesn't adapt. It just gets all the force and it tears. Along with that, the lateral meniscus on the outside actually has a small little muscle called the popliteus muscle that kind of helps move it as we bend the knee, so it kind of gets pulled out of danger. The medial meniscus doesn't have that luxury, so all in all, it is more likely to be damaged. Now, when it does get damaged, we have two types of mechanisms of injury. In terms of how do we injure the meniscus, we can do it in two ways, really. There might be more, but there's really two types. There's traumatic, which tends to happen in younger, sporty people. And what tends to happen is they plant their foot, so their foot stays rigid, they bend a little bit, and they twist. So it's usually when they change direction, often in things like football, American football, squash, and tennis, where they have a surface where they lock their foot in place, either because they have studs on grass or they have a very high friction environment like an indoor squash court, and then they turn, their knee has a lot of force going through the meniscus and it tears. So we have traumatic. Now, halfway between that and degenerative, which we'll touch on, we have just kind of wear and tear. So some people, like long distance runners, will have just lots of micro traumas to the meniscus because they're bending it again and again. This might also be the case in people who have an occupation where they're kneeling down or bending down a lot, or even going up and down stairs all day, where they just have lots of micro traumas that eventually build up over time. The other one, the really big one, is that degenerative category. If someone is over 35 to 40, so 35 to 40 and above, they tend to be a degenerative meniscus. This happens throughout the body. Things tend to lose a bit of their water, they dehydrate, the quality just diminishes a little bit, and this happens in the meniscus. It just loses its ability to dissipate energy, and eventually you just get a little tear, even from small trivial things such as missing a step or just turning out of the car. Those sort of things can then tear the meniscus, but really it's not traumatic, it's more degenerative in nature. So we have those two big categories, traumatic and degenerative. Along with that, we can actually categorize it into different types of tears. So the meniscuses are really C-shaped, so they're shaped like the letter C. Now the one on the outside is a bit more O-shaped, but in essence they're C-shaped where the middle doesn't touch. And we can categorize it into what we call longitudinal tears. So that means it's kind of torn front to back, so it's longitudinal and it follows the curve of that meniscus, so that's longitudinal, and that tends to make a little flap like this, what we call a bucket handle. The other one is what we call a radial tear. So that means the complete opposite to longitudinal. Rather than going forwards, front to backwards, it goes side to side. So a radial tear. So it comes from the inside outwards. We also have what we call a horizontal tear. So if you imagine the meniscus is C-shaped, it sits on your knee, you can actually slice it either like a roll or a scone, and you're slicing it in half. So you have a horizontal tear. Now that might lead to something called a meniscal cyst, where you get kind of an outpouching of the meniscus, and so some people actually get a little bulge out of the side of their knee, what is called a meniscal cyst, usually because of those horizontal meniscal tears. The final one is what we call a root tear. So where the meniscus sits on the top of the shin bone, if for some reason it kind of gets peeled off that shin bone, not always the nicest of thoughts, we call that a root tear. So you have the posterior horn, which is at the back, and if that tears off, then we call it a posterior root horn tear. Nice and long sentence for you there. So those are the types. So you have longitudinal, radial, horizontal, and root tears. Now, one final thing to just add in that little section is that the meniscus blood supply comes from the outside in. So the outside third of the meniscus has fantastic blood supply. And as you go to the middle third and then the inner third, the blood supply gets less and less, to the extent that the inside of the meniscus doesn't really have a blood supply. It gets most of its nutrients from the liquid which is actually within the knee joint. So it's like a lot of other cartilages in the body where it gets a lot of its nutrients not by blood vessels and therefore blood, but actually the amount of nutrition is actually just floating around within the joint. And that will really carry through to management, where if you injure your meniscus on the inside where it doesn't have great blood flow, then the management is not always as good compared to on the outside where there's a lot of blood flow, where it is really nice. Now, if we quickly touch upon the symptoms, the meniscus does have a good amount of nerves within it, which is one thing why it can tell the body where the knee is, but also why it can actually generate pain. Sometimes things like bones don't always tell us a great deal of information as to exactly where the pain is, which is why things like osteoarthritis, where you get some wear and tear of the cartilage and the bone, it sometimes can be very hard to pinpoint it. It's usually quite a broad pain in the area, but the meniscus does have those nerves, and so we usually feel the pain in what we call the joint line. So where the two bones of the knees meet, we have the little line where they join. So what we call the knee joint line. So it can either be on the inside if it's a medial meniscus or on the outside if it's a lateral meniscus. Sometimes it does hurt if you palpate and you touch it, just because there might be some swelling, or you might actually have a very outer edge of the meniscus torn, and so it hurts to palpate. But that's not always there, but what usually is there is that it's painful right on the joint line. We usually also get some swelling. And one important note with the swelling of a meniscus is that it actually comes on a little bit delayed. So usually a day to 2 days after we injure a meniscus, that's when it swells up. That is very different to a ligament. So if you tear a ligament, the swelling is within a couple of hours. It's really quick and the knee swells up. Compare that to a meniscus, which is 1 to 2 days later, it just takes some time for that fluid to build up. So if you wake up one night or one morning even, and your knee is then swollen up, sometimes that can be an indicator that it's a meniscus because actually you injured it the day before. Sometimes you don't notice, and it's just that now that it has swollen up with that delay. So those are the two big ones. We have joint line tenderness, so it hurts right in the joint line, and we have that delayed swelling. The next one, which isn't always there, is what we call mechanical symptoms. So this is either a clicking noise or actually a catching or a locking. This happens where the meniscus is torn and the part that's torn has now flipped upwards. It is more common with the longitudinal tears where it then flips upwards, or the horizontal ones where it flips up that way as well. So if we have a tear which for some reason now it's flipped upwards, as we move the knee, we're just going to catch the meniscus, either giving us an audible click, or we're actually going to feel like our knee stops, so it locks, or we can feel that it clicks. So those are what we call mechanical symptoms. They're not always there in all meniscal injuries. We have to have a very specific type, one where we actually get a little flip upwards. In terms of the diagnostics and how we diagnose meniscus, it's usually the whole clinical picture. We look at how an individual has injured it. Was it a younger person in a sporting capacity where they've done a big turn? Or was it sort of an older person, that 35 to 40 years old and above, where they might have missed a step, gotten out of the car, and then that's what's injured it? But we're really looking for a bit of a knee bend and a twist. We then look for that joint line tenderness, that gradual swelling, and a few clinical tests. And most of the clinical tests, what we do is we bend the knee gently, we then twist it, and we then straighten and bend the knee in that position. And what that does is it loads the meniscus, and if that's really tender, then that gives us a real good clue that this is probably a meniscus. We don't often have to do an imaging, so an MRI scan of the meniscus, unless it was really traumatic and they're probably going to need surgery, so we need to grade it. So if it's traumatic in a young person, they will probably need surgery, so you probably need an MRI in that situation. If somebody's tried rehab, it's not worked, then we probably need an MRI in that situation as well. The only other one is if it's a bit ambiguous, if we're not entirely sure, then maybe we need an MRI. But usually meniscus is diagnosed clinically between how it happened, how it's presenting, and what makes it worse. And usually that's then enough for a diagnosis of a meniscus. And that then leads us to where we really want to be. How do we manage it? And when we look at management, the two things that really dictate, do we need surgery, do we need rehab, are one, how old we are and how it happened, and the other is really what type of meniscus issue it is. And those two ones really dictate, do we need surgery or rehab? And when we consider it, all we're really looking for is, if we do rehab, how successful will it be? And if we compare that to surgical repair, is there much difference? Now, surgery always carries risks with it, so we always want to make sure that the surgery will be that much better than rehab before we consider it. So in essence, the default is rehab, unless surgery clearly will be superior, in which case we choose that. Now, what are those situations? Well, the first one, which I already touched on, is young people and a traumatic meniscus issue. If somebody is a sports person, they're young, and they did it in a sporting capacity, they're more likely to respond well to surgery. Firstly, they are young, so the healing will be really good, so they'll bounce back from surgery quite nicely, hopefully. It's traumatic, so it's probably quite a large injury, so that's usually where surgery might be more required. Along with that, if you have any clicking or locking, so those mechanical symptoms, that's another one where surgery is better. If the meniscus has flipped upwards, and that's what's giving us the click and the catch, then that doesn't tend to respond very well to rehab. It responds better to surgery. And then the last category that we say you're probably best to do surgery is if you have had about 6 months of physical rehab, it's clearly that you're not improving, even if it's slow, you've completely stalled, then we perhaps look at surgery. On the other hand, when should we rehab it? Well, if we are over 35 to 40, then usually we start with rehab. It's more likely to be a degenerative meniscus. They don't tend to respond great to surgery, so we tend to do a lot of symptom management and physical rehab. So if it's degenerative, you're a little bit older, you're more likely to initiate a physical rehab to start. The other one is if we have a very small meniscus tear and it's really stable. So if we don't have any clicking or any locking, and we suspect it's not a really big meniscus tear, then we do physical rehab. Now the question of course is, how on earth do we know if it's a small tear without doing an MRI? Now usually the reason we know is often because we try rehab and it fails. So that small tear and rehab failing tend to go hand in hand, where we usually just attempt physical rehab 3 to 6 months. If it's completely failed, then we MRI it, and sometimes that then shows us that, oh yeah, the type of meniscus tear was never going to heal, or it's just too large for that to be attempted. But usually you at least try physical rehab. And that's really the broad algorithm of it. If it's a young person and it's traumatic, or it's locking and clicking, or rehab has failed, we go towards surgery. If it's more degenerative, we're a bit older, it's either a small one and we don't have any clicking or locking, then we try rehab. And if that fails, then we go back to surgery. And that's really how we categorize it. And that's the end of the video there. So hopefully that was helpful. If you do need help with your meniscus issue, I do have a physical rehab program for the meniscus. So thank you for watching. And if you do enjoy these videos, then you might enjoy one of these videos I've made before.